This is Selma Schimmel in San Antonio at the 33rd annual meeting of the San Antonio Breast Cancer Symposium, and we are joined by one of the group room regulars on our program. Hi, Dr. Julie Gralow. I've lost
Selma.
count. I don't know how many years we've been doing this.
I think we were talking 10 years or so.
And we began in another country, and here we are, still talking. You're the Director of Breast Medical Oncology at the Seattle Cancer Care Alliance. You're Professor of Medical Oncology at the University of Washington School of Medicine, Associate Member of the Fred Hutchinson Cancer Center, Vice Chair of the Southwest Oncology Group's Breast Cancer Committee in Seattle, Washington, and really a great key opinion leader and advocate for women all over the country.
Thanks, Selma, and I'm thrilled to be here with you.
Thanks. And especially as we've moved from radio into video.
Yep.
So we are going to talk about bone-targeted drugs with you, an area that you've been researching and is really a passion of yours clinically.
That's right. So we now have two classes of bone-targeted drugs. All of our past communications have been about the class called bisphosphonates, which are osteoporosis drugs. They're drugs for reducing fractures and bone loss, and also drugs we use to treat bone metastases. And drugs in that class include, common drugs like Fosamax and Boniva, and Zometa is another one that we use to treat bone metastases frequently. We now have a new class of bone-targeted agencies, and we call them rank ligand inhibitors, and the drug that was just approved this year in both osteoporosis and the treatment of bone metastases is denosumab. It's called Prolia when it's used for osteoporosis, and Xgeva when it's used to treat bone metastases.
So everything we're talking about today is not only relevant for the breast cancer survivor, but we're talking about women's health in general.
Absolutely. And men also have problems with bone loss and bone metastases, so it's relevant to everybody.
So let's talk about some of the concerns and issues that we have learned over long-term use with some of the earlier compounds, and where there's been improvements, and the drugs that maybe we're learning have less side effects.
So the bisphosphonates, that older class, good drugs. They've reduced lots of fractures and helped lots of patients with bone mets. We know that long-term use of those drugs, they build up in our bone, and because they just totally inhibit bone breakdown and they last for a long time, the normal bone structure is actually disrupted. You normally, in everyday life, have a little bone breakdown, a little bone building, and you get the scaffolding effect, so that if we fall, it's a little bit spongy-like. You need that, and you need that constant back and forth. And when the bisphosphonates get given and laid down in the bone, they prevent the bone breakdown. So you just keep getting build up and build up and build up. And on scans, the bones can look very dense, but they can be more brittle, actually. If you had a fall, you'd have a higher rate of fracture potentially. So we worry about what we call this long-term bone quality from the bisphosphonates, which is why it's exciting that we have another class of drugs that's much more reversible in short term.
Was that also the issue with the jaw?
Well, osteonecrosis of the jaw, which is essentially exposed bone in the jaw that is not healing. Lots of times it's caused by a tooth extraction, and then it doesn't heal normally over the course of what you would expect. So osteonecrosis of the jaw isn't quite the same issue. We truly don't understand exactly why these drugs have caused that, because they don't actually really limit bone healing per se in other sites except in the jaw. But interestingly, with early data now on denosumab, the drug in this rank ligand class, that doesn't appear to be different between the two groups. What we're really hoping that the studies will show, based on the mechanism of action and all, is that the denosumab, because it's not so permanently laid down in the bone, it's an antibody that is in and out of the body fairly quickly, it won't have those fractures. But to date, unfortunately, the small but real risk of osteonecrosis of the jaw does appear to exist for denosumab.
The evolution of denosumab, the understanding in the laboratory or the development of the drug itself, the distinguishing factors are what?
Mm-hmm. So the osteoclasts, which are the drugs that destroy bone, are the main target of all of these drugs. Now, there are off targets, and actually these drugs can also impact maybe the immune system and angiogenesis, you know, the blood vessels, et cetera, and maybe even tumor cells directly, which is another issue. But the way that this rank ligand pathway in the development of a mature osteoclast is very important, and it actually impacts how osteoclasts from their very birth, you know, the baby osteoclasts, as they're maturing, it impacts that pathway. And it's an antibody, a monoclonal antibody. We have other drugs, famous ones in breast cancer, Herceptin, Avastin, that are antibodies too. Very differently given. It's given subcutaneously under the skin instead of either by mouth, which some bisphosphonates are, or by vein. So
does that mean absorption could be improved?
Well, compared to the oral, absolutely. And, you know, an interesting point, especially with our long-term, you know, survivors, is you want to stay away from the infusion room, you know. So instead of having to go into the infusion room to get the intravenous infusion, any doctor's office really can give a little under the skin or subcutaneous injection of denosumab.
How often?
Well, it depends if you're treating bone metastases or osteoporosis. Right now, for osteoporosis, it's twice a year. And for treatment of bone mets, it's still monthly, just like you would have given Zometa.
And again, the side effects that a woman who's using it for osteoporosis, what can she expect to feel after the injection, if anything?
Pretty much, you know, nothing. I mean, there's no drug that has no side effect. The most common thing she'll experience is the little injection site, you know, reaction. This drug is really quite safe compared to placebo in a large trial called the Freedom Trial for osteoporosis. Really, the side effects are minimal.
So the real issue then is, you know, compliance and adherence, in the sense that the patient is proactive in seeing their doctor and getting their injection, but easier than when you have to rely on taking a pill every day.
Right, and a pill that can cause some GI discomfort. I mean, that's one of the main side effects of the oral bisphosphonates is esophagitis and irritation of the lining of the stomach and the esophagus. You don't have any of that with denosumab.
And now let's talk about the woman who's taking it for metastatic disease.
Right, so a very nice study in the treatment of breast cancer patients who had bone metastases was done. So they had newly diagnosed bone metastases. They were starting treatment for that. The standard of care had been Zometa every month, and the comparator was monthly denosumab. And the results of that trial showed that the time to what we call the first skeletal related event, which would be a fracture or the need for radiation or surgery, and a few other endpoints there, the time until something happened in the bone that was serious was substantially delayed, and denosumab was shown to be superior there. When you compared the side effects, zoledronic acid given monthly in particular can cause a little bit of kidney toxicity that we have to watch out for, so we always have to draw blood first. You don't have to do that with denosumab. Zometa can cause something we call the first infusion effect, flu-like syndrome. Denosumab has none of that. But the osteonecrosis of the jaw, you know, a handful of cases in both arms.
So for the woman who's dealing with metastatic disease, what could this mean for her now in the clinical setting of the drugs she may have been taking, in this case Zometa, as we look at maybe changing standards of care?
Right. So when a patient with breast cancer is diagnosed with a bone metastasis, which, as you know, is a common site of recurrence, then the standard has been Zometa or zoledronic acid once a month, kind of indefinitely, along with other breast cancer therapy. So recently, denosumab, now called Xgeva in treating bone mets, was approved in this indication, and it was based on a head-on randomized trial of Zometa, which was the standard of care, given monthly, IV, intravenously, versus denosumab or Xgeva given once a month, underneath the skin subcutaneously. And the results of the trial, which led to the drug's approval, was that denosumab or Xgeva was superior in terms of the time to what we call the first skeletal related event. That would include time to a fracture or the need for radiation to treat pain in the bone or the need for surgery and things like that. So a serious event. And so denosumab won and was superior in terms of delaying the time until a skeletal event like that happened. And that led to its approval. And in terms of side effects, it didn't have the kidney toxicity that makes you need a blood draw before every Zometa dose. It didn't have what we call this first infusion effect that Zometa causes that feels like a fever. But what it did have was about an equal number of cases of this osteonecrosis of the jaw. It was a tiny number in both arms, but it was about equal between the groups. We had been hoping denosumab would not have that side effect.
So do you think this means that ultimately Zometa is going to be phased out?
Yeah, it's a good question. Right now, Zometa is substantially cheaper. And so there's the whole reimbursement and cost, et cetera. There's the convenience issue of not needing an infusion with the denosumab. And there's less toxicity in terms of what patients are feeling. So it'll be interesting to see how that plays out. You know, right now I'm writing some of my first prescriptions for this, and I'm contacting insurance companies for approval. I've looked at the pricing, and so the guidelines right now are saying that either is an option, and based on cost reimbursement, et cetera, either could be given.
And what about the uptake of the denosumab within the community setting?
Well, it's a superior drug in patients with bone mets in terms of preventing a skeletal-related event. I mean, personally, any new patient that has newly detected bone metastases, I am starting on denosumab. Any of my patients who is already on Zometa but is having progression in her bones, I am switching. My patients who are on Zometa and they're doing fine, I'm not switching now. I don't have a good incentive to tell them they do better right now in that situation. And that's the message.
Cost may also be a driving factor here.
Cost and the reimbursement, right?
And what concerns me, though, is in the discussion with doctors, if a doctor knows a drug is more costly and may be sensitive also to an economic, financial situation of a patient, I'm concerned about choice and options, and that the patient may not know or be given the option to choose, even in the face of cost. I mean, people have maybe family members or other ways. I'm worried about choice if patients aren't given choice, and then of course if they are given choice, if their insurance companies deny that choice.
So good to remind us all of that. That's clearly critical, and that's why the guidelines that we're all reevaluating right now after the approval of denosumab are actually stating either is an option. Denosumab delays skeletal-related events, but we recognize that convenience and cost and all of these things and patient preference and goals will have to be taken into account. So actually the guidelines are right now going to say either.